So, good afternoon. It is my privilege to be presenting this talk here. I shall be speaking the ABC of glaucoma. The first thing what a practitioner sees or when he or she suspects glaucoma is looking at the optic disc. For a proper disc evaluation, direct ophthalmoscopy is no longer in vogue. You need to have a stereoscopic evaluation with one of these lenses, 60, 78, or 90D lens. What are the basic parameters you need to look out for? Number one is the optic disc size. Number two, the optic cup, neuroretinal rim, any vascular changes, any hemorrhage on the optic disc, any nerve fiber layer defect, and last but not the least, the peripapillary atrophy or the chorioretinal degenerations. The optic disc size, why it is very important. If you see here on the left, you see a small disc with the Welschalin spotlight, it is smaller. The spotlight is about 1.5 millimeters in diameter. Whereas on the right, if you see the disc, it is long, it is a large disc compared to the size of the spot size of the direct ophthalmoscope. The optic disc cup, the vertical optic disc ratio is more important, and then you need to look out for any disc asymmetry. The optic cup asymmetry, also you need to take into consideration the size of the disc, whether there is an anisometropia here. Obviously, the slide on the photograph on the left, the disc is larger than compared to the right. Why it is important to know the cup size, why it is important for this? You see this disc, we know that 1.2 million axons are passing through the nerve, this disc. If you see this disc, here the cupping is something like 4.4 to 0.5, and the same 1.2 axons pass through the optic disc. If you see this disc, it is a large disc. Here the cupping is about 0.7, but if you see the neuroretinal rim area through this, the same 1.2 million axons pass. If you see all the three discs, small, normal, and large disc, what is the lesson that we know? That cup disc ratio varies with the size of the disc. Cup disc ratio on its own is not significant. That means a large cup can be normal for a large disc, a small cup can be abnormal for a small disc. So the importance varies with the disc size. This is precisely the reason why you need to make a conclusive decision as to what is the size of the disc you are looking at, and this is a surrogate for the neuroretinal rim. Next comes the neuroretinal rim, whether it is pink, whether it is pale, whether there is any focal notching. And always you must look out for this axonym, that is the isn't rule, so-called isn't rule, that the inferior neuroretinal rim is thicker than superior, which is thicker than the nasal, and which is thicker than the temporal. So you need to look out for any discrepancy. If the disc is straight, if there is no tilting of the disc, the isn't rule, if it is not followed, then you need to suspect glaucoma. Then comes the important thing, contour versus color cupping. If you see the disc on the left side, like the color cupping may be looking this, but if you look at the right one with the dipping of the vessels in the periphery, that is the real amount of physical amount of contour cupping that you need to take into consideration. The vascular changes, we all know, the nasal shift of the vessels, bearing of the vessels, and the bionetting of the vessels need to be looked at. Optic disc hemorrhages, always rule out a hemorrhage rather than the hemorrhage will not look at you. You say, look at the disc carefully and say that there is no hemorrhage. The nerve fiber layer defect, generally it is seen better with a red-free light. And how does it look? If you see here, a small hemorrhage here, this hemorrhage, now this extends as a dark wedge, touches the disc, base of the disc, and then it fans out into the periphery. How does it look like? With a colored image, the nerve fiber layer defect can be seen here, which is appreciated better here as in the red-free light. The peripapillary atrophy or the chorioretinal degeneration. PPA can be congenital or commonly seen in high myopes. PPA seen de novo or in non-myopic eye should be viewed suspiciously. The peripapillary atrophy, it consists of the central beta zone and the peripheral alpha zone, and very rare nasally or circumferential. So peripapillary atrophy, the alpha zone, it is peripheral to the beta zone and the disc margin. It is irregular hyper or hypopigmentation. It indicates thinning of the RPE, and that can give you a relative scotoma. whereas in the beta zone, it is central to the alpha zone and the optic disc margin. This is peripheral to the disc margin. It appears as a marked atrophy of RPE. It is a resultant of marked atrophy, and then visible choroidal vessels and sclera can be seen in this zone, and this results in absolute scotoma. The chorioretinal degeneration can give you a general reduction of sensitivity on the Humphrey visual field. Whenever you are looking at the disc, always follow Joe's rules. Until proved otherwise, all discs have glaucomatous changes, all glaucomas have RNFL defect, all glaucomas have disc hemorrhage, and all myopes have glaucoma. Look out carefully for these factors and say no, they don't have glaucomatous changes, they don't have. Look out for it and say that there are no RFNL changes. Look out and say that there is no hemorrhage, and always suspect glaucoma in myopes and rule it out. So the structural and functional correlation in optic disc evaluation is very important. What I showed you in my first few slides was the size of the optic disc. Here if you see, you are seeing a large optic disc with a 0.75 cupping, but the visual field is absolutely normal. So this is a normal enlarged optic disc with a normal physiological disc. If you see here, I said the isn't rule. The inferior rim should be thicker than the superior, which should be thicker than the temporal, the nasal, and that should be thicker than the temporal. If you see here, there is a notch in the inferior temporal region here that results in the form of an early focal defect in the superior nasal step. Now, if you see this disc here, the inferior neuroretinal limb, especially the contour cup, there is a dipping of the vessel here. It's almost near excavation of the inferior neuroretinal rim, which results in a dense superior arcuate defect. Now, if you see this disc here, there is, if you say color cupping may be 0.7 or 0.75 from this point to this point, but if you see the dipping of the vessels, this is near total cupping, which results in dense diffuse suppression, and then in such cases you need to do a central 10-2 perimetry to mark out the real of the defect and then follow up the patient. Now, if you see this here, the chorioretinal degeneration can have a normal visual field, but there can be a general diffuse suppression in the total deviation plot. If you see this here, always look out for temporal pallor of the optic disc, especially if it is seen in both the eyes. You won't be surprised, you may get a henium-anopic defect. The other eye shows a henium-anopic defect. So with that, like whenever you are sitting in your OP, whenever you are sitting in the thing, what is the first thing? In institutes, the patient gets a visual acuity, patient gets a NCT, then the patient comes to you. NCT, though, the moment, when do you suspect glaucoma? That is when you make a habit, don't see the disc in your routine with your direct ophthalmoscope. Always make a habit, have a 90 diopter lens with which you can definitely see the disc, even in undilated pupil if you want. First thing that you look at is the disc. The points that I've enumerated, if you follow this basic ABC about disc evaluation, you will pick up the right patient whom you can label as a glaucoma suspect and then subject that patient to further investigation. And the cornerstone of diagnosis of glaucoma ultimately boils down to structural and functional correlation that I have shown in my last few slides. Thank you very much.
Thank you, sir, for the wonderful talk. Before sir leaves for the meeting, I think the PGs, I'm not sure whether your PGs or even completed your PG. Do you have any questions
about disc evaluation?
About the disc evaluation. How many of you really draw the disc in your OPD? Do you really draw the optic disc with the zones? Do you really do that? Okay, so one thing. Yeah. Second thing is on, you have explained about the cup, sir. Yeah. So would you like to really, tell our PGs, what will be the type of cups that we really see in adult glaucoma versus the pediatric eyes? Usually the pediatric eyes are a little different. One specific thing is like, when you're really looking at the concentric cup, that will be very typical of pediatric glaucomas. Adult glaucomas, usually we have the superior notch, inferior notch, and then there is a temporal thinning. All those things you can really see with the RNFL loss. But in a pediatric case, it is completely different. You may see that as only a 0.5 CDR with the central cup, but you really may not be able to see lot of RNFL changes because the RNFL is so thick. Even if some is gone, you still may not be able to appreciate how much it is lost. So that is a very typical of adult versus the pediatric glaucomatous changes. Even the juvenile open angle glaucomas, again you will be able to see something similar to that. Concentric enlargement with the RNFL loss, but adult will be having more of a typical superior and inferior loss. But at the same time, sir, to you, when you have a very high IOP, like in angle closure disease, the cup may not be same as the PYAG. So
yeah, naturally, like in the angle closure case, especially in the early part, the onset is acute, and there the disc may appear normal. The disc can be normal. It can be a primary angle closure. We need to address the angle closure issue and stabilize the eye before the cupping real glaucomatous disc changes appear in the optic disc.
So that is very typical of, you will not be able to see a cup that will be very shallow, like 40s and 50s IOP. The cupping will be very shallow, but the disc will have a little bit of a pallor. Pallor in an optic disc, it doesn't mean only it is neurological. It can be glaucomatous also, or it can be a combined glaucomatous and the neurological. So you got to be a little careful. So when you are doing the assessment of glaucoma, you have to make sure that you have the structural as well as the functional changes to be seen. So you do the visual fields and you do the structural analysis like a fundus photography and also the OCT. So it gives you the clue of what is really happening there. It is not enough for you to just understand only the structural changes. Okay, so that will give you, because of the high IOP, the collaterals will disappear on the disc. It is not only the collaterals, the small vessels, because the high pressures, it goes for an ischemic change. So that's why the cup will appear to be very shallow. And also, you might have seen the patient with the large like 0.8, 0.9 CDR. I just want you to, if you can really answer this question. And the patient comes after, say, a couple of months later, or say 3 or 4 months later, the cup completely will disappear. Can you say which condition it happens like that? Any one of you? There is a 0.8, 0.9 deep cup, disappears in even a month or 2 months or 3 months. When does that happen? Any idea? Where does the cup gets filled up? So once the cup is getting filled up by the retrograde axoplasmic flow, I'm just giving you the clue, when does that happen? Usually when the IOP is very low, right? When does that IOP, low IOP happens? Post-operative. You do the trabeculectomy in a high IOP, especially in younger ones. When the IOP becomes 3 or 4, what happens is the cup gets filled up completely by the retrograde axoplasmic flow. So you will see that absolutely there is no cup. The disc will be completely without any cupping. So you might say, why this patient got operated for glaucoma? So that is a very typical. So that is where you need to have the visual fields. So it gives you the clue, okay, this patient had a very advanced cupping. Because of the low IOP, the cup is filled up. So you need to have a fundus photograph before and just before the surgery and prior few visits whenever the patient starts coming in. So that is absolute mandatory that you need to have the fundus photographs. By looking at the disc images, you will be able to understand what is really happening. Is it a neurological damage? Is it just the cup which is corresponding to the glaucomatous changes? Or is it the RNFL? Say, for example, you have a superior RNFL loss. Is the superior RNFL loss is glaucomatous or is it non-glaucomatous? Some may be just arising from the disc margin, some may be little away from the disc margin. Those arising from the disc margin with the notch is more so relating to the glaucoma. But if the RNFL loss is little away from the disc margin and you still have an RNFL loss, that is called as a peripheral RNFL loss. That is a very typical of high homocysteine levels, B12 deficiency, Alzheimer's disease, multiple sclerosis, thyroid-related diseases, all these things. So it is important for you, like what Sar was mentioning, looking at the notch, looking at the RNFL loss is extremely important. Take the fundus photographs, like Sar has shown so many photographs with typical RNFL loss. And same way, I want you to understand a small inferior RNFL loss, it may be arising from the disc again, but you really may not have the notch. Those patients are again from a disease called the multiple sclerosis. So these are very, very difficult cases, but you will have to really understand from where these things can come in and how many other diseases that we'll have to keep in our mind. So thank you so much, sir, for your wonderful